Mm. And I'm the president and CEO for the Sickle Cell Foundation of Tennessee. I would like to thank you for joining us on today as we host the statewide sickle cell disease town hall meeting. Today is a very special day. Today is World Sickle Cell Day, a day that is commemorated by the United Nations for those individuals who are experiencing sickle cell disease. This is a day that we go out and we create awareness and visibility for people not only in the United States but across the globe. Here in the state of Tennessee, we are very proud of the work that we're doing, and we would like to bring you some additional information. So on this day, we're going to talk to some very special people who will give us more information on what's been going on, even during COVID-19, and just as well as what's happening for health equity, along with additional education and awareness. Our very first guest will be Dr. Patricia Adams Graves. Dr. Graves is the incoming chairwoman for the Sickle Cell Foundation of Tennessee. She's also Professor Emeritus for the University of Tennessee Health Science Center for Medicine and Hematology. Dr. Graves will join us today, and she will talk about improving access to care. Dr. Graves?
Thank you very much, Reginald. It's an honor and a privilege to be thank you very much. It's an honor and a privilege to be a part of this town hall meeting for our sickle cell community and others. I want to just outline what I'm going to discuss today. First, I'm just going to sort of define sickle cell disease, and then I will talk about how we want to improve access to care. So let's start with sickle cell disease. Sickle cell disease is a genetic, lifelong blood disorder found in individuals of African and Mediterranean descent. It also expands out to Saudi Arabia and Indians. However, the bulk of the ethnic groups that are affected are of African descent. While there are millions and millions of sickle cell individuals living in Africa, there is only 100,000 individuals living with sickle cell disease, at least the most common type in the United States of America. Therefore, sickle cell disease is classified as a rare condition, defined as less than 200 individuals living with the condition. So a lot of people don't understand that, and because of that, it creates a lot of ignorance just from the few number of people that are treated across the United States. And the middle of the United States, there's hardly a sickle cell individual living in the middle of the United States of America. The most are in the South, Northeast, and the West Coast. As compared, if you think about it, as compared to individuals living with diabetes, cancer, heart disease, there are millions and millions of people living with those conditions. It's very common. Everybody has heard of breast cancer and breast cancer awareness. They know the color is pink. They know the awareness symbol. But who knows the awareness symbol or our color that represents our condition? Now, the manifestations of this condition include anemia, so they're tired. They just don't have enough blood cells, and the red blood cells are defective due to a single mistake in the gene that codes for hemoglobin. Their cells are sticky, stiff, and they create a lot of inflammation inside the vessel wall as they're flowing through the bloodstream. It also is associated with vascular occlusion. In other words, they plug up blood vessels, and that creates a lot of pain. If you could just think about somebody putting a rubber band on the tip of your finger, and you say to them, well, you can't put it on tightly. You cannot take it off until we tell you. Well, you can't turn off that inside the body in the blood vessel. And so they suffer with pain. Matter of fact, pain due to the vascular occlusion is the most common reason they seek medical care in the emergency room, or they're admitted to the hospital for a pain crisis. The third manifestation, we talked about anemia, vaso-occlusion, and the third manifestation is the inability to fight certain infections like bacteria. And I know during this COVID time, it's kind of scary for them, but they have a difficult time fighting certain types of bacteria. The inflammation that's caused in the body is a new thing. We've learned recently that even if they don't have pain, the inflammation is ongoing throughout their life, and it really disrupts and damages the inside of their blood vessels. And those cells that are participating in that are called endothelial cells, big old word. And so it's an indirect inflammatory condition as well as a blood disorder. The life expectancy in sickle cell is reduced. The average is close to midlife, but different subtypes of sickle cell disease may live longer than others. My oldest patient in our site at Diggs Krause is about 80 years old, so God's in charge. The treatment is very limited. After more than 100 years in America, we now have 4 drugs, and in the last year and a half, 3 of them were just FDA approved. Because of the pain, sickle cell individuals oftentimes may need at least once or twice a year opiates. And you know the opiate crisis that we just got over. Now we're in a public health crisis. These patients present with sudden, unpredictable pain. They go to the emergency room, and the emergency room doctors sometimes feel that they're drug seeking and drug addicts. Do we have drug addicts in the sickle cell population? Yes, it's comparable to the general population. But I would say over 90%, even more than 90% of our patients are good people. They are not addicts. They're not drug seeking. All the more reason for us to improve access to care. One of the terms that I've gotten used to over the years is medical home models. Medical homes are described as something that is disease specific to a chronic condition. Matter of fact, they call them family medical homes because whenever someone has a chronic condition such as sickle cell, the whole family is affected. They have to sit with them when they're in the hospital. They have to put up with the stigmatization of being a drug addict, etc. So medical homes are one model of healthcare delivery that would work. We have the goals of medical home models is to improve both 3 big areas: access to care, timely, quality care, and to minimize the cost of care, because you know insurance companies and the system, they look at cost. As far as I'm concerned, just pay for their care. But I'm biased. I've been taking care of sickle cell patients for 30 years. It's in my family. So, of course, I understand cost. You got to keep the lights open, but that should be the last of the quality measures. But how do you do that? Let's start with access. Access to me, in part, is to just bypass the emergency room. Emergency room care is at least 5 times greater than regular outpatient care. But if someone is in an uncomplicated pain crisis, there's no fever, there's no pneumonia, a lot of those situations are treated in the outpatient. The outpatient medical home for sickle cell needs an infusion suite, or what we call a day hospital with long hours is possible. Some day hospitals across the country only close down for 4 to 6 hours every 24 hours to bypass the emergency room. We treat at our center pain crises that are uncomplicated, and even doing all of that right, about 20% of them will still require to be in the hospital. So we understand that, but we've still bypassed the ER. We could admit them directly from our clinic area, our outpatient center. We also can treat uncomplicated pneumonias with IV. Some IV antibiotics last more than 24 hours, so you give them a dose and bring them back the next day and the next day and give them, 3 days of antibiotics, and then you can switch them over to something by mouth, but it has to be uncomplicated. Their oxygen levels have to be good, and we know how to handle that. Quality is more difficult because it requires intense education to the nursing staff, the entire medical team. It includes first the patient needs to be educated. And believe me, they're not patients every day. There's a life behind here. Their families need to be educated. The nursing staff, to me, is my major point of reference for education. They're with the patients more than anybody else when they're in an event, especially in pain. And they have to not be so biased against our patients who are living with lifelong pain. Get over it. And I almost like to say, if anybody is a drug addict on opiates, they deserve to be, because here they are minding their business in school and they, bam, having pain, excruciating pain that requires IV opiates. And it's quite apparent. And guess what? About 22% of deaths occur in the midst of a pain crisis. So people are not in tune to look behind the pain. They look cute, handsome, but they got to look behind the pain. So that is my take on improving access to care in sickle cell disease.
Okay. Well, thank you, Dr. Grace. All that information was very, very helpful. And as we go towards the end of the conversation, we will bring you back up with the other panelists to fill any questions, as well as just have a live discussion. Our next speaker is someone that's known throughout the state of Tennessee, Alexis Gordon, who is a sickle cell advocate as well as a mentor. She's also the director of the Sickle Cell Foundation of Tennessee, Nashville and Memphis office, and works throughout Middle Tennessee with us to ensure that we're reaching as many of the sickle cell population throughout the state. At this time, I would like to bring up Alexis Gordon, and Ms. Gordon will talk about a day in the life. Hi, Alexis. How are you?
Hi. Thank you, Reginald. Can you hear me?
We can hear you very well. Please
Terrific.
go ahead. It's your time now, and we would like to hear from you to talk about a day in the life as relate to what you experienced on such a special day today.
Absolutely. Absolutely. Thank you all for tuning in. Wanted to just give you a perspective of an actual sickle cell patient. I live with sickle thalassemia beta 0. And was diagnosed with sickle cell thalassemia beta 0 probably in my teens. So I wanted to kind of break up my lived experience to kind of talk through the day in the life of a sickle cell patient, from like childhood to young adulthood to adulthood, to try to give you a little bit of my perspective. So as a child, I had parents who were very knowledgeable about our healthcare. My mom was a nurse. So when I was diagnosed with what was called then sickle cell trait, my mom knew exactly kind of what to do in terms of staying on the cusp of different treatments, different plans, management plans, life plans. So we're told as children early on that it's not safe to marry someone who has sickle cell trait or that have sickle cell disease. So I probably learned that when I was in my early teens, that my parents were saying, be aware of who you choose as a mate, and when you become an adult, because that child would likely have sickle cell disease if I marry a mate or pick a mate that has sickle cell trait or sickle cell disease. So early on in childhood, my parents started to educate me on being my own self-advocate. So by the time I'm in my teenage years, I am very aware of the disease itself, the different categories of the disease. With my mom being a nurse, we also had doctors in our lives. So we were very aware of the different treatments that were around and available. So I was blessed to have that. I am well aware now that I'm an advocate for it, that not all families, have what I had as a child growing up. So it's imperative that we, teach that at a young age to sickle cell patients. So I'm big on teaching young children and young kids on how to navigate this pain that we have being a sickle cell patient. So we did have nurses and doctors in our lives, so we were very well aware of the treatments and the diagnosis that I was tapped with, as well as taking folic acid since I was probably age of 4 and still do to this day. So just some of those different treatments along the way that we learned on how to manage sickle cell disease. Fast forward, if you will, to the young adult a young adult time frame that I experienced, getting ready to go to college, getting ready to hang out with friends, wanting to now start, living what's considered a young adult life, and going through college, maybe transferring to a different state or going to college out of state, having to have my own pain management plan, or pain crisis plan, making sure that my roommates, my friends, everyone was aware that when I had an episode, of what to do, where to go, and what to give me. So those types of things I've started to learn in my young adulthood. Learning my body basically is what you're doing at that point. Lessons learned related to exercise, related to eating, related to stressors, becoming well aware of what triggers basically a sickle cell crisis. So one of the things I started to learn was how to manage it better in my young adult age. Also, you start to learn to make sure everyone else around you, whether it's a mate, whether it's a friend, whether it's a classmate, whether it's an aunt, uncle, if you're going out of town, having all of those things lined up in my young adult years. Fast forward to adulthood. So now I'm in the stage of considering marriage, childbirth, maybe being a little overweight, considering weight loss. All of these things start to play into what we can do as sickle cell patients. So again, if I was told in my childhood years not to pick a mate who had sickle cell disease, that was one of the things that was highlighted in my head. So I didn't. But I wanted to make sure some of the things we think of as adults is whether or not my children can have sickle cell disease. And so we learn how to determine if they will or they won't. One of the biggest ways too is to not have a child with a mate that also carries the trait or the disease. So in adulthood, I learned to manage the stressors more. I was able to have children. I had 2. During those different times, I did have sickle cell crises that I had to go to the hospital for. But again, at this point, you're learning how to live with sickle cell disease. It's a learned and lived experience. So reducing the stressors in adulthood, keeping a peaceful environment, learning how to reduce your stress, maintaining a pain management plan, knowing what the pain triggers are. A couple of the things I learned when I became an adult had to do with temperatures. And the change in temperatures that can drastically affect our body and whether or not we go into a crisis. So just becoming aware of those things. And those are the things I share with adults now. Those are the things I share with young adults now to start learning their body, because we have a lived experience, which makes us experts in our own lived experience. So yeah, living happy and healthy lives is definitely possible with sickle cell disease.
Thank you very much, Alexis.
You're welcome.
And we'll also bring you back during the closing session to fill any questions that we have, along with just an overall roundtable discussion.
Certainly.
So I'd like to thank you.
Yep,
So the next
absolutely.
person we're going to bring up is Dr. Artangela Henry. Dr. Henry is a nurse practitioner at Methodist Sickle Cell Center. Dr. Henry will talk about something that's very, very important, the new FDA treatments. You just heard Dr. Graves lightly touch on them when she talked about the fact that for over 100 years, there had only been 2 treatments for those individuals who were living with sickle cell disease. But in November of 2019, the FDA did approve a couple new treatments, and Dr. Henry will talk about the current treatments as well as the most recent treatments and how they play into those individuals who have SCD on a daily basis. Dr. Henry, thank you for joining us, and we'd like to hear from you as relate to the new FDA treatments as well as the current treatments that were out prior to the most recent ones that were approved.
Thank you, Reginald, for inviting me to this platform today. I want to just go ahead and jump in and kind of talk about some of the things that we are currently using for sickle cell disease. One thing I do want to point out is that Dr. Pat Adams-Graves really kind of did a segue to help us get into what some of the manifestations of sickle cell disease are. And so those very medications that we use today really target those disease processes and what happens with sickle cell disease. So historically, as mentioned before, with this existence for over 100 years, sickle cell disease did not really have medications. And so we're now coming into the realm of having these modalities to kind of help with the disease process itself. So one would be hydroxyurea. It is a very old drug that is used before oncology uses, but what we found through our research is that hydroxyurea actually helps to increase fetal hemoglobin. Fetal hemoglobin are red blood cells that do not sickle. And of course, we understand with sickle cell disease, those are red blood cells that are sickled. They are sickle shaped or moon shaped, crescent moon shaped, so to speak, and they are very hard to get through vessels, which leads to the vaso-occlusion. So hydroxyurea helps to increase the fetal hemoglobin. Those red blood cells, again, that does not sickle. And with that increased fetal hemoglobin, there's a robust amount of red blood cells that are bigger and are able to circulate throughout the blood system. So that's one drug. The next drug would be Endari. Endari is also called L-glutamine. L-glutamine is an amino acid that is used. It is indicated for sickle cell disease in individuals who are 5 years of age or older. It does come prepared in packets in powder form that you can add to liquid, like water or juice. You mix this powder into the liquid itself, you drink it. That's done twice a day, and those individuals tend to start to have an improvement of their acute complications with sickle cell disease. Endari was approved in 2017. So now we kind of move fast forward a little bit and talk about 2 of the newer drugs that were recently FDA approved for use specifically for sickle cell disease. And so it's very, very exciting to have these 2 new drugs as well. I would start with the first one. We mentioned before in this webinar that sickle cell disease causes a lot of vaso-occlusive crisis or sickle cell pain. And so one of the drugs that has been approved by the FDA based on the SUSTAIN trial, which is a clinical trial that kind of shows that this medication works, is Adakveo. Another name for Adakveo is crizanlizumab. So Adakveo is a medication that does attach to what's called P-selectin. P-selectin is what causes the blood to take on a sticky factor. So if you can remember earlier in the webinar, Dr. Pat Adams-Graves did mention that these red blood cells are sticky when they're going through the blood vessels. P-selectin is what causes this stickiness and these adhesions that take place in the blood vessels themselves. With this stickiness, it causes those red blood cells and the other blood products that are kind of flowing through our vessels to stick to the inner walls of the endothelium of the blood vessels. When all of this happens and there's a cascade of the sticky vessels, sticky blood, that tends to adhere to each other, it causes excruciating pain for our patients. So the Dacvio was approved, FDA approved November 15th, 2019, for sickle cell disease, specifically indicated for vaso-occlusive crisis. So what the SUSTAIN trial has shown is that it decreases vaso-occlusive crisis or sickle cell pain crisis by nearly 50%. And that speaks volumes to our patients because of the pain that they have. This medication is IV preparation, which means that individuals will have to have this medication administered intravenously through their IV, and this is done monthly. So that's one of the drugs that's been recently FDA approved. The next drug is Oxbryta or Voxelotor. Voxelotor is a medication that's indicated specifically for sickle cell disease. And its main target is that it reduces hemoglobin S polymerization. So if we can just go back just a little bit about the discussion that we've had, hemoglobin S polymerization is when those sickle cells are those sickle cells. So we have regular red blood cells that are round, but when those sickle cells become misshapen because of mutation that takes place genetically with those red blood cells, they turn into these rod-type shapes. That rod-type shape is a process or cascading of hemoglobin S polymerization. When that takes place, that process, that cascading process, the red blood cell is deoxygenated, which means there is not enough oxygen in that red blood cell to be delivered throughout the body into the organs. It was mentioned before that sickle cell disease does cause anemia, and that's why individuals are anemic, because they don't have enough oxygen within those red blood cells. Oxbryta was created and studied with the phase 3 HOPE trial to actually increase the affinity of oxygen within the red blood cell. And what that means is this particular medication helps to increase the production of oxygen, and it raises the hemoglobin, which in turn decreases the chances of individuals with sickle cell disease being more anemic. So there you have a total of 4 drugs that we are currently using to help with the treatment of sickle cell disease. It's very exciting, especially with the newer drugs that we are using now, because we have something that, number one, can help with the excruciating pain of these individuals that go through this every single day, most of them, and for others, just to be able to have something that really helps with their pain outside of opioid therapy. That's not to say that opioid therapy is not going to be used or does not need to be used, because we definitely need something for acute crises and to get them out of pain. But to know that we have a medication that can help decrease pain helps a lot, as well as having medications that can help increase the hemoglobin levels in the red blood cells and increase the oxygen that are in the red blood cells helps a lot, because this is an opportunity for individuals to live a life full of quality. Less pain is what we're hoping for. Less anemic, so you have more energy is what we're hoping for. And just to live a life a full life. And these medications can definitely help individuals to live that way.
Wow. Well, thank you, Dr. Henry. You gave us a lot of information, which was very helpful. And I'm certain we will have some questions as relate to the new medications. So we will discuss those at the end of the session around the roundtable discussion. Thank you very much. At this time, I'd like to bring up our next speaker, Dr. Michael R. DeBond. Dr. DeBond is the founder and the director of the Vanderbilt Meharry Center of Excellence in Sickle Cell Disease. He's also a professor of pediatrics and medicine, and he's also a physician at Vanderbilt Medical Center. We work very closely together, and I would like to bring up Dr. Michael DeBond, who will talk about something that's very important, that's dealing with COVID-19, something that has hit not only the United States, but our country, and how has that affected the sickle cell population. Dr. DeBond, thank you very much for joining us.
Good afternoon. Can you hear me okay?
Yes, we can hear you very well.
Great. So can I see the chat? If I say something in the next 10 minutes, I can answer a question directly, or do I just give you the talk and we'll be done?
Well, you can just talk, and we're going to handle the questions at the end of the discussion during the roundtable discussion.
Okay. All right. Great. So let me first start off by saying that it's great to see those pictures right behind you, Mr. French. I have been able to contact the artist, and with God willing, we'll be able to purchase those pictures and donate them to the American Society for Hematology, uh, so that those wonderful pictures that have been uh, put together by an individual with sickle cell disease can be shared for the rest of the world in perpetuity. So it's time will tell if we ever get a chance to get out of this COVID-19 and get those pictures down to the American Society of Hematology where they could be displayed. But I'm glad to see those pictures as a backdrop to your frame. So second point, I just wanted to acknowledge the importance of having these type of communications and the advantage of this new era, where today I was supposed to be in Palo Alto, but was zoomed in for a graduation ceremony, and gave a sickle cell disease talk in Amsterdam about 4 hours ago to a group of individuals just like you all. And now I'm here back in Tennessee talking to folks across the state. So it's my pleasure to be here. So what I'd like to do here is actually share my screen about COVID-19, because it turns out that it's less about what I tell you today and more about what you should stay vigilant in understanding what the changing data points are in sickle cell disease in regards to COVID-19. So, Mr. French, can I share my screen?
Yes, you should be able to share it.
Okay, share screen. All right. Share screen, and then I will give me a second to bring this up. Okay, can you see this information here on your screen? I can't tell if you can or not. Can you? What do you see? Do you
Well,
see
we
this?
see some emails that we need to take.
Oh, all right. Well, there's nothing confidential about the emails. Can you see this now?
There we are.
All right. So, yeah. So what I want to show you is that a colleague of ours in Milwaukee has put together a registry for sickle cell disease. And as those who know me well, I try very hard to talk less about my opinion and more about what are the data. So when you look specifically at this international registry, this is what you see for individuals who have COVID-19. You have a total of 219 individuals who've been reported. The average age has been 29. The standard deviation is 14, which means that there are children and older adults who get this disease. You can see the predominant number of individuals is unlike in the general population, is actually women. This may reflect demographics of being an African American and women going outside the home to take care of their family. You can see that the vast majority of these individuals are actually African American, as you would suspect. And then you can see that 70% of these individuals have hemoglobin SS, which is about what you expect in the general population. But you also see a scattering of individuals with hemoglobin S beta thalassemia plus and hemoglobin S beta thalassemia 0, much higher than in the general population of sickle cell disease. So this idea that individuals with sickle cell disease who have S beta thal 0 or S beta thal plus are not at risk for having this complication is just not the case. Let's see, I'm trying to make sure, because my camera's on one screen and I'm looking at the other, so I hate to have this dichotomy here. So if you look at the symptoms prior to 3 years prior to developing COVID-19, you can see that the symptoms are predominantly pain, and that's either in a hospital or tested or treated in the emergency room. I want to skip down to the other comorbidities of individuals with this disease. You can see here, I'm not sure if that's legible. I don't know if this is legible or in your screens, but you have asthma is the #1 risk factor among these individuals, 18 years of older. You can see there's also the current use of cigarettes. Let me hit pause for a second and just say that if you're an adult and you have sickle cell disease, or you're an adolescent and you have sickle cell disease, stop smoking. Now, I know that's easier said than done, but this is a disease that attacks your lungs. The fact that the disease attacks your lung, we know for a fact that 2 weeks after you stop smoking, your lungs start healing, and we can see a clinical benefit when we look at the microscope at your lungs. So work very hard to stop. Today is the day to stop smoking. This will improve your overall health. And if you happen to get COVID-19, this will decrease your likelihood of having a life-threatening lung infection. Of course, diabetes, we know about this. And note that the current cigarette smoking and diabetes is about the same in terms of its contribution, hypertension, and then other chronic diseases. So what are the symptoms in sickle cell disease if you have COVID-19? Again, this is driven by data. The #1 symptom, unfortunately, is the #1 symptom we see in sickle cell disease, which is pain. Over 60% of the individuals with this disease who have COVID-19 will present with pain. They will also present with pneumonia. Pneumonia and acute chest syndrome are exactly the same. Okay, so anytime your provider says, oh, you have pneumonia, you don't have acute chest syndrome, that's not the case. Pneumonia and acute chest syndrome are synonymous. They mean the same. We treat them the same. Anybody with acute chest syndrome gets treated with antibiotics because we recognize that one of the risk factors or one of the causative agents associated with acute chest syndrome is an acute bacterial infection. And then renal failure. Any of our adults is particularly is focused on adults because adults in sickle cell disease are the group that have the highest rate of end-stage renal disease. That's when your kidneys fail and you go into dialysis. So any adult with sickle cell disease on dialysis, they are in a high-risk group, very high-risk group, and they need to take all precautions that we know and you all have heard multiple times regarding shelter in place. In terms of interventions, you can see that the #1 intervention is ED visits, followed by hospitalizations, ICU admissions, it's very high, and then transfusions. You can expect to have a transfusion. For those families out there who are Jehovah's Witness, you should probably have an offline discussion with your provider around what you should do in the event that you have COVID-19 infection and you refuse to have any transfusions. What are the alternative strategies that we can consider? My short talk won't allow me to go into this in detail, but I think it's a very important proactive strategy to work out with your primary care provider or your hematologist. And these are the locations around the world that have included participants in the registry thus far. In terms of the deaths, the death rate is higher than you would expect. In the general population, we expect a death rate about 1 to 2%. However, in individuals with sickle cell disease, we expect there's actually a death rate of 6%, 6.8% to be exact. So clearly for individuals with sickle cell disease, which is no surprise to the individuals on this conference, there's a much higher rate of death. And for this reason, the folks at Nashville, at least Dr. Kasim and I at the Vanderbilt Meharry Sickle Cell Disease Center of Excellence, made a decision early on in March that the best way to treat COVID-19 is to prevent COVID-19 from occurring in our children and adults. So we've worked extremely hard to ensure that we can activate a telemedicine program for our population and so that our children and adults will not have to come to see us in a hospital setting or in a clinic where they are at continued risk for ongoing COVID-19 infection. So let me hit pause here, see if there's any additional questions. Before I do, I just want to show you one other website that I think would be important, and for some reason it didn't show up, Mr. French. So let me try to get to the ASH website. So this is another website that I really would like for you all to know about. This is the American Society for Hematology. ASH is the authoritative home for sickle cell disease. Any activity that's published in ASH has been vetted by many different international specialists multiple times. And let me just attest to the fact that this is a very rigorous process. So can you see my screen now? Can you see it? Yes, no? Mr. French, I can't.
Yes, we can see your screen.
And is it readable? Can you read it?
Well, it was, but I'm trying
Not
to.
now? Just let me know.
Not now. Went back to the emails.
Oh, snap. Okay, let me go back.
There you go. There you are right there. Let's take it went back. Let's
All
see.
right. Sorry about that. Hold on one second. I'm just trying to.
Okay. Got quite a few emails.
That's my life. So hold on one second. So let me. I see you're looking at the other screen. So let me.
Dr. DeBond, the
Yes.
chat screen was showing. You did find it at some point?
Yes, I got it. Here we go.
Sure.
All right. It's just on the other screen, and I'm. All right. So this is current. We update this every 2 weeks. Okay. So this is updated information for your families who have a loved one with sickle cell disease, or if you happen to have sickle cell disease yourself. Now, what I want to point out here is not only the date, but here are the individuals who contribute to this work. And of course, for those in Tennessee, you know Dr. Ataga, who runs the adult program at the University of Tennessee. Here are the common questions around management of sickle cell disease and COVID-19 or SARS-CoV-2. Let me just hit pause for a second because I think the terminology is critical for you to understand. When we say an individual has SARS, SARS stands for severe acute respiratory syndrome, COVID type 2. That means you have been infected. When we say that you have COVID-19, that means that the infection is serious. So it's a little bit like when we say you have HIV, which means you've been infected with the virus, versus when we say you have AIDS, which means that you have been compromised by the virus and you're a susceptibility for you're an immunocompromised individual. That means that you're at risk for having life-threatening infections associated with the infection. So here are the points that we try to make clearly to providers. When you're in doubt and you're not sure what should happen, I would suggest, this is how I try to support my families, and Dr. Kassim supports his families. We would like for you to be aware of this information in the public domain. And then it's okay to challenge us. I mean, we have to be on our P's and Q's when we're managing you. We have to be on our A game. So you can say, hey, have you seen the ASH guidelines on management of pain and sickle cell disease, or whether I should come off of my antihypertensive medication, or whether I should get transfused if I have acute chest syndrome? That's how we operate as providers when we're at the top of our game. We read the literature, we discuss it, we have our pros and cons, and then we come back to you and say, this is what the evidence shows. This is what we believe is the right strategy, but here are some other options for you. It's a shared decision-making at every step. It's shared decision-making at every step. So Mr. French, let me hit pause here. I would also encourage the group that if they want to look at their references, these are articles that have been published, and there are links, how to manage different aspects of sickle cell disease in the midst of a COVID-19 pandemic, or if the individual has COVID-19 infection and needs to be treated properly. Let me stop and see if there's any questions.
Okay, great. Trying to remove the screen. Okay, there we are. So thank you very much, Dr. DeBond. Now at this time, we will move to, we have several questions, and a lot of good questions, as a matter of fact. So I guess I'll start with you, Dr. DeBond. The first question is, what is the difference between telemedicine and inpatient? And should someone with sickle cell disease do telemedicine or go see their primary care physician?
Right. So let me be clear about this point. All right. So when I have a telemedicine visit, I actually spend as much time, if not more, with my families than I would with a face-to-face. What are the upsides? Well, the upsides of a telemedicine visit is that in this pandemic is that you don't come to the hospital where the waiting rooms may not be particularly set up for social distancing. People come to the hospital because they're sick. So we only are recommending our families. Now, some families say, look, I'm not going to do telemedicine and I'm going to come in anyway. Okay, fine. But we have selectively identified individuals who are sick, acutely ill. Those individuals we want to see in the emergency room or we try not to see in the clinic. But sometimes you come in and you don't know you have it. And it's clear from the literature that 40 to 50% of the individuals who spread the virus are asymptomatic at the time. So you sit next to somebody 6 feet away, not coughing, but breathing the same air. They could have COVID-19 because they're asymptomatic. We're trying to limit all of that exposure. And so to the ability that we can, telemedicine is the preferred strategy. If you need to have lab work, which we encourage our families to do, particularly if you're on hydroxyurea, then in Nashville, we can send you to Walgreens, believe it or not, in your neighborhood. So hopefully that answered the question, but our strongest preference is to have a telemedicine visit. The last point I want to make about the telemedicine visit is that for many of our families, we know they're working poor. So this results in having to miss work, having the kids take off from school, and having to drive here. Some of our families live 2 hours away. I mean, you can imagine, I can have a 30-minute visit, go over your labs that were done locally, give you all the anticipatory guidance, and you don't have to leave your bedroom or your kitchen or your living room. Versus taking 2 hours to come down or an hour and a half to come down, spending the gas, getting something to eat, spending the gas, get home, and then having this wait in the parking lot or wait in the waiting room where you might be at risk for developing COVID-19. So that's the rationale.
Okay, thank you. The next question is for any physician that would like to answer it. Is there a cure for sickle cell disease?
Well, all of us can answer that on this panel. The curative procedures actually are done at Vanderbilt, quite a few of them. Actually, we refer patients for bone marrow transplant, for gene therapy, and they've been very gracious. Some of these procedures, just in preparation to get the matching done between the siblings, is quite costly. And Dr. Devon's group with Adatola Kasim have, kind of reduced the cost of some of those things. And actually, 2 of my patients, maybe 3, come back and say hi. They don't even want to come to the sickle cell clinic anymore because of those guys. But we have some cures, and we're very, very happy about that. Michael, you could go into a little more detail if you want about how the retroviruses are used and all of that if you want. But I'm just wanting to acknowledge the gratefulness that, they actually provide that procedure.
Well, if you don't mind, Dr. Graves, I may want to go to a couple other questions because we only have about less than 7 minutes. And we have quite a few I'm looking at as they're coming in, which is good. So I may move to another question. And this is regarding the new medications. Is it easy access to the new medications that have been approved by the FDA? Dr. Henry?
I guess I can take this one, huh? So both medications that have been FDA approved have special patient assistant programs within the pharmaceutical companies that have worked really hard to get these medications started. So for instance, Adactio is one of those medications that is under the umbrella of Novartis. Novartis does have a patient program that they use. They also have some patient navigators that are helping to really bring this medication to those individuals who really need it. So the best thing is to check with whatever center you're located at with getting services for your sickle cell disease. See if they are connected to the pharmaceutical companies, and those pharmaceutical companies will direct you to their patient navigators and their patient assistant programs to really help make sure that you have what you need for as far as getting these medications. The other medication, which is Oxbryta that I talked about, is a medication that is used under Global Blood Therapeutics, or GBT. GBT as well has a patient navigation system, as well as a program that they use to help really ease the cost of these medications. Now, granted, both of these medications are very costly. These are some very expensive drugs, okay? But these companies are really trying to make sure that they are affordable in the sense of being accessible to our patients to be able to use, because how they are used throughout the disease process of sickle cell disease. So those would be my recommendations in regards to getting those medications paid for, or at least the assistance.
Okay, thank you, Dr. Miller. Another question I think is very important. What is the difference between sickle cell disease and sickle cell trait? Open for whomever would like to address the question.
Yeah, the fact that we have to explain it. First of all, I appreciate the question. Let me just be clear. All right. And look, this means that we've done a poor job of educating you. If you have to ask this question, we have failed you. Our system has failed you. Okay. Your doctor has failed you, period. Now, after giving that disclaimer, let me just explicitly state that sickle cell trait is generally not a disease state. By definition, individuals with sickle cell trait have one copy of the S globin gene. Individuals with hemoglobin SS have two copies. Individuals with S beta thal 0 have one S copy and one beta thalassemia 0 copy, or one beta thalassemia plus copy, or one potentially C copy with SC disease. That whole constellation of having both an S and a C and an S and a B plus and an S and a B0 and S and a C is called sickle cell disease. Sickle cell anemia is referred to as SS. Very confusing. But the point is that for individuals with sickle cell trait, we expect them to have a normal lifespan, and only in situations of extreme climate, extreme stress, high altitude, extremely cold, extremely humid, heat exhaustion, will the manifestations of sickle cell trait occur. And so that's a whole nother, it takes us an hour to go over this with the families, but that's the Reader's Digest version of what sickle cell trait is. And if you talk to a provider, and if that provider cannot spend the time with you to explain the difference between sickle cell trait and sickle cell disease, bottom line, get a new provider.
Okay, thank you, Dr. DeVon. So we have about 6 minutes, and at this time, I would like to spend 3 minutes to give each one of you all a closing statement, and then I'll close out with about 3 minutes. I want to thank each of you all for participating. We have another one that's sponsored for the sickle cell population and the general public on June the 29th at 6 p.m., and we will start announcing that on next week. But I want to thank each of you for your time. We have a flood of questions coming in, and I apologize to the sickle cell population as well as the general public that we did not have enough time to answer and address all your questions. But at this time, I'll give each one of you all a closing statement, and I'll start out the way that we started the panel discussion. Dr. Graves, you can go first in about 30 seconds to give a closing statement.
Well, first of all, Reginald, I was hoping that you could maybe document those questions and we can some kind of way post them and answer them that way, because sickle cell is a rare blood disorder in America and it's much misunderstood. And I tell you, any kind of information we can put out there is where. So my whole closing argument is with you to post all of those questions, and I'd be happy to help answer them. And you can ask the other panels, but this is a very difficult, complicated condition, and we need to always work toward reducing pain and suffering.
Okay. Alexis? Alexis, you have a closing statement?
Here.
Or
yeah. Hey, yeah, just a couple things. I want to emphasize that as an adult, you can live with this disease, making sure that you have a couple things in place: your pain management plan, understanding your pain triggers, and living your life through those things. So I want to make sure that everyone is aware that although we have a disease, it is something that is livable. So those are my last 2 points.
Thank you.
Thank you.
Dr. Henry?
Yes, thank you. I think the thing I want to express more importantly is that those living with sickle cell disease, you have a voice. And as a provider, as providers on this panel, we hear you. We hear you, and we do want what's best. We really want what's best for you. So it's important for you to really seek out a provider who understands the disease process of sickle cell disease and who are not afraid to really start using some of these newer modalities for treatment in sickle cell disease. And then someone who you can have a conversation with. I agree wholeheartedly that you need to understand the disease process itself and what it means for you. And just be an advocate for sickle cell disease for yourself, for those that you know who have sickle cell disease, and seek out those opportunities to learn and be teachable.
Thank you very much. Dr. DeBond, final closing comments.
Yes, so first of all, Mr. French, thank you for this forum. I will encourage you to continue to have these forums once a month so we can educate the community. I don't think it'll be a lack of energy on the provider side. So as long as you have an audience, I'll be here. Okay, so that's number one. Number two is that it's lovely to see the panelists, see some brown faces, particularly beautiful brown women. I enjoy that visual, given all the chaos of the world. I'd like to yield my time to the question about cure as opposed to closing remarks, and just say that you're going to get a lot of propaganda. I don't think there's any other way to describe it. Person A is pushing therapy X for cure. Person B is pushing another therapy for cure, or even pushing treatment with these very expensive drugs, which have some benefit, but unclear what the combination benefit of these drugs will be for when you're on hydroxyurea if you have SS. So I think the best strategy is a strategy we have embraced all along, which is get educated. We'll provide the resources for you to learn about the disease and learn about the treatments. Some of this can be through our town halls, but we can spend an hour talking about these new drugs, not 3 minutes or 5 minutes or 10 or 15, talk about the pros and cons. We can have individuals with the disease speak about being on the drug and what helped and what didn't help. Likewise for curative therapy. That's a 2-hour conversation easily when we sit down and talk to families. You can't digest all that information in 1 hour. So again, congratulations for pulling this off, and I'm happy to come back every month that you put it together.
Thank you very much, Dr. DeBond. Prior to closing, I'd like to announce a program that we announced today for World Sickle Cell Day. It's our Feed Our Families program. This is a program that is jointly sponsored with United Way of Nashville, Global Blood Therapeutics, GBT, and Kroger, where we are giving out Kroger gift cards for food to sickle cell patients, not all the sickle cell patients, but to sickle cell patients. So they are being administrated through Regional 1, Methodist, Sickle Cell Comprehensive Center, Vanderbilt Sickle Cell Center, and Meharry. And I'd like to thank you all for participating. Obviously, we have 4,000 sickle cell patients throughout the state, so we do not have enough for everyone, but this is a start of a program that we will be launching, that we have launched and we will be doing throughout the year. So in case if we run out very soon, we do have more coming. So I would like to announce that. And I also like to thank each of you for joining us today from 3 to 4 p.m. We will be back with a webinar on June the 29th at 6 p.m. And you will hear more information regarding it. We will have a different set of panelists, and we will be doing this, as Dr. DeBond said, on a monthly basis to ensure that we are educating each of you all. And we also have an upcoming panel with St. Jude, and we will be announcing that very soon as well, who's one of our partners, even though we focus on adult population, but we have that panel coming up as well too. So you will see more on our website on next week. Thank you very much for joining us. May God bless you. Please stay safe and healthy. Thank you.